everyone. I'm Dr. David Wild in for Steve Stites, our Chief Medical Officer. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio this morning. And we are joined again for our normal Tuesday segment by Secretary Dr. Lee Norman from the Kansas Department of Health and Environment. But first, Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. How does it look today, Dana?
Yeah, Hays is holding steady. They have 3, but all of those are actives, none in that recovery period. But for us here at the health system, not getting worried, but there is concern. Yesterday we were at 12 active infections. We're at 13 active infections today, still 5 in the ICU, 2 on the ventilator, and then 12 in that recovery period. But again, at the end of last week, we had 8 active infections. We know that known cases, diagnosed cases, are going up in the United States. We know around the metro area, it's still, our 7-day rolling average is still under 100, but we are seeing more cases on a daily basis too. So that's the concerning thing, is just those. And of course, as you had talked about last week, the majority of how we can gauge really how things are going is by hospitalizations, if you're talking about things like Michigan.
Yeah. And this is in line with, in fact, exactly in line with sort of our own internal forecasts for how many patients we would see in the hospital this week. So nothing alarming, I think you're right, but very possible that by the end of the week we could end up seeing doubling from where we were last week. And if that happened 2 weeks in a row, then we would start to be concerned. So, all right, before we jump into our discussion, are there any reporter questions this morning?
Yeah, hi, this is Jonathan Shorman from the Star. I want to just kind of get to the elephant in the room on Johnson & Johnson and ask Dr. Norman if he does plan to request that vaccinators in Kansas suspend administration of the J&J vaccine for now. And also, if that is the case, if he can comment on kind of if that is how much of a setback that is to vaccination efforts at this time.
Yes, happy to comment on both, Jonathan. Good question. And yes, we've already issued a press release, or it should be going out right about now, that is in line with what the FDA and CDC have done, and that is we're putting a pause until which time the federal agencies, including those two, look hard at the numbers. The numbers of cases are quite small. I believe 6 cases of the cerebral venous thrombosis, venous sinus thrombosis, have occurred out of almost 7 million doses. So it's a small number, but you can't turn a blind eye to something as significant as that. We therefore are falling in line with that. We have not had a case of that reported to our knowledge through an event reporting system in Kansas, which is good, but still something that needs to be very judiciously approached and looking at the evidence, and that hence the pause. Now, second question, I don't think it's going to be a huge setback, because you'll recall in the last few weeks we've talked about all the Johnson & Johnson vaccine we were supposed to be getting, but for a variety of production and other reasons it never materialized, or very little did. So it won't have a big impact on our administration rate overall, because the J&J product is a pretty small one. We did have some scheduled for J&J clinics scheduled for 8 o'clock this morning, and unfortunately those have been put on hold, or fortunately. Hate to inconvenience people. And of course, our recommendation will be to shift over and use the existing 2 products, which haven't shown to have any of these same complications that have been thought to perhaps be a problem for the Johnson & Johnson.
Dana, we were talking just a minute ago. This is actually probably one of those signals again that our safety mechanisms are actually working as designed.
Yeah. 100%. We know that there's a lot of vaccine hesitancy. One of those arguments for that vaccine hesitant population is it was pushed through too quickly. We don't know if it's safe. But these mechanisms have been in place since day one. And they continue to be. And I think this is a great example of saying we've identified something that has a signal of being a possible bad side effect or affecting safety, so we're just going to put a pause to this. So I think that's a good story for this as well, understanding that there are people up and awake 24 hours a day looking for these types of things to make sure that it is safe for the people receiving the vaccines in your community, in the country, in the world. So I think that's a good story.
And most importantly, 1 in a million, actually more, right? Or 6 out of 6.8 million. We found the signal here, paid attention to it, and we'll decide whether it's some sort of correlation, whether there's some other factor, maybe another medical condition or another medication there's an interaction with that's playing into this. It's interesting as well. The questions are many more today than we have answers. The population, the 6 that had this complication, were all female and between 18 and 48, I think, if I read the numbers correctly. And so there's something there maybe. Just lots of questions that we don't have answers to, but I think at the end of the day, this message that all of those systems that are put in place to make sure that administration is safe and side effects are managed, and we understand very clearly, is this just what was going to happen anyway, or is this in some way correlated with or caused by a specific vaccine? We'll have answers to that here soon, and the pause is, I think, from that perspective, as Dr. Norman was getting at, while it might be for some a little bit of an inconvenience, it's definitely the right thing to do.
And I think the other issue that's coupled with that safety and just the desire to make sure that it's safe is the transparency as well. I mean, this was pretty evident early on today, and so I think transparency and safety are of the utmost importance.
Any other reporter questions on the line?
Hi, guys. It's Taylor, Channel 41. Good morning.
Taylor.
Is there a window right now of time that someone who has received the J&J vaccine should feel uncomfortable? Hey, maybe I'm one of these, like I should be watching extra closely. Is there a window of safety if it hasn't happened to me yet? For example, the thousands of people that got the J&J vaccine at Arrowhead, that's been 3+ weeks ago. Are they, quote unquote, in the clear, or at the same time, as if there's someone who got it yesterday, are they less so because of the timing of this at all?
I think from the news reports, and Dr. Wild and Norma can correct me, I think we have seen those events anywhere from 2 days to about 13 days after their dose. So I think, we can't say never, but I would think anything after 2 weeks, you're probably more than likely okay. But again, I think we still need more investigation, but that has been the reported time frame, is 2 days to 13 days after that dose.
Any other questions?
I've got a couple of reported questions. This one is from the Wichita Eagle for Dr. Norman. Jason wants to know, Kansas has one of the best case rates in the country and has one of the smallest proportion of cases attributed to variants of concern, and he's citing the CDC data. Do you think, Dr. Norman, these points are directly related? Why do you think Kansas has a lower level of variant cases than other parts of the country? And how likely is it that variants will cause a new surge in Kansas like is happening elsewhere?
Yeah, terrific question. And I don't think we have the exact answer on that. We do have 2 variants identified so far, fairly geographically dispersed around the state. They haven't really taken hold and entrenched and become the dominant strain. So yes, yesterday we recorded 483 new cases in 3 days. That's a fairly low number compared to where we were, 0 new deaths yesterday to report. So those strains, and I'm just predicting that the other strains that haven't shown up here yet will, because we're not an island completely detached from the rest of our states. So it wouldn't surprise me. I think of this as a road race, really, between the vaccine administration and the wild strain, the normal strain of virus, and these variants that are out there. So I think it really emphasizes, the need to continue to do the anti-contagion measures of masks and distancing, and then vaccine, because we know the vaccines work against these strains, yet to be determined if it's as good as against the normal strain that is out there. So I think it's going to require constant vigilance, more testing, more wastewater testing, and then to do the things that we know are successful that we're pressing on now, which is, by the way, why we're the 5th best in the country on new cases and the 6th best in the country on hospitalizations. So keep up the great work and get vaccinated.
Channel 41 is asking, will the J&J hold impact our vaccination clinics here at the health system?
Yeah, great question. So we have not actually received any J&J ever here in the Kansas City market for administration to patients. So we've not given any, and we didn't have any plans for that over the next couple of weeks. So the impact on our operations and our clinics is negligible. We have had some doses to our other campuses across greater Kansas, but to my knowledge, none of them have been administered yet. I think just this week was the first delivery, if you will, of inventory of the J&J vaccine, and of course we'll hold those from administration today or tomorrow as well for any clinics that were planned. So we have plenty of vaccine available and appointments available, and it's not the J&J, at least not this week, and hasn't been so far. So we'll keep on doing what we've been doing.
And a follow-up question to that is, can you give us the signs and symptoms of a blood clot?
So in general, blood clot signs, symptoms, right? People will talk about leg pain, calf pain, some shortness of breath, swelling of an extremity. Those are probably the most common. Interestingly enough, this is not, though, this sort of what we're describing here is not a blood clot in a leg, like a deep venous thrombosis as the blood clot that we're used to hearing so much about. So Dana, you want to take it and run with it from there?
Yeah, I mean, the best that we can understand, just like you said, normal blood clots, we think about blood clots in the legs, so just calf, swelling, pain, like you said, or blood clots in the lung, shortness of breath, cough, maybe some chest pain. Those are our typical things. I think what we have seen from, again, the news reports about Johnson & Johnson, but then also if we want to, bring in AstraZeneca to this, I would like to keep it out. Again, we don't use AstraZeneca right here. But a lot of the case reports, and again, I think a lot of that information is available on New England Journal of Medicine, showed that there was blood clotting in the veins within your skull base, the cavernous sinus, the venous cavernous sinus thrombosis. So I think a lot of that is going to be headache or pressure in your sinuses and around your head in that way. And those are the best details that I can go with based on the newest information that was presented today about the Johnson & Johnson. We know that those blood clots were those cavernous sinus thrombosis in that area. So I'm thinking you're really going to be looking at increased sinus pressure or headache, and don't know if Dr. Norman has anything to add to that as well.
No, that's the clinical signs. You've got it.
I think it is interesting, the other sort of clinical association or correlation here is that there's some activation of platelets for this sort of clotting, or that's sort of the thinking at the moment, which is different as well from the mechanism for most deep vein thromboses or clots in the legs or the arms, where you think about one of the risk factors we talk about there is immobility. So whether you're bedbound in the hospital or you've heard about those blood clots for people flying long distances, for example, and not moving on the airplane, that's really because blood pools in the veins. This is different, and so, or at least this cavernous sinus thrombosis is a little bit different, the mechanism of all of this. And so we'll understand, I think, more as we dive into it. But I think it will be important to separate out, at this point at least, this is not looking like those symptoms of normal blood clots. That I say normal, those that we think about in legs for all those reasons that we're so familiar with.
Yeah, we certainly know our colleague Dr. Alt in the advisory committee that he's on for the CDC and FDA is going to be working overtime today, and we know that they are investigating the FDA, the CDC. Everybody is investigating those cases right now. So.
All right, and then I have a question from Donna Pittman with Channel 9, and she sent us a little bit of video. She said that she's wondering about these new strapless N95 masks. She wants to know, are you familiar with them? It's supposed to seal around your face, and it's supposed to help also with fogging. And she wants to know, what do you think? What does the panel think about these masks?
Yeah, so I did a little bit of digging because this question came up recently as well. this is not, first, it's not something that we have any experience with here in our system, so can't speak from direct experience. It does have a NIOSH approval, which is sort of the one of the safety approvals that would say that this is a device that provides respiratory protection. But it's also noted that the FDA has not approved it, and it has an EUA, an emergency use authorization, ability to be used in healthcare spaces. The concept of sealing off and preventing fogging and being more comfortable, those all sound like good things, but we don't have any experience, and I'm not sure that there's a lot of real-world experience in the healthcare environment based on the information that's available about the product. I don't know, Dr. Norman, have you seen or heard anything about this in other areas?
We haven't changed our guidance based on this yet because we do want to know what the FDA says and further testing. You know, masks can be tested for the amount of air movement across them. We did that early on a year ago with a lot of the shabby products actually that were flooding our market. And you heard me maybe a year ago talk about this, that some of them were so lousy they wouldn't even make a good coffee filter, let alone a good air filter. And we can measure that. So we're waiting to know what the result of that testing is. I think for now, if it's primarily for the use of preventing fogging of glasses, which I can appreciate, of course, put another mask over the top of it, because that will still then give you the protection of against the movement of air, and it'll prevent your fogging of glasses without having to rely on the adhesive one to prevent you from transmitting or receiving the virus.
Yeah, I think another important thing to remember is we want to make sure that there's a tight fit and seal around the edges. If you remember, the CDC had kind of published different guidance on can you use 2 masks. You certainly can. But the big point of that guidance was to say it needs to be better fitting and tight fitting to block expression of virus out into the environment. So.
All right, that is all the media questions that I have, if there's no more media on the line.
All right. Well, Dr. Norman, we'll spend a few minutes here talking about what's happening from your perspective. We've already hinted just a little bit about the variant conversation, that at this point, what we know appears to point to signs that we're doing well in Kansas from the standpoint of the impact of variants. Mm-hmm. How much, though, does the potential for further variant spread in our community, how much does that concern you?
Yeah, it's a lingering concern, and we've increased the amount of whole genomic sequencing, and we've increased the reach to smaller wastewater treatment programs around the state. So I think that our vigilance is going up all the time. It's reassuring that we haven't seen a marked uptick. To the contrary, in some communities, we see it continuing to drop. And we have seen a pretty good correlation with the amount of disease. So I guess we're all kind of holding our breath in terms of the vaccine administration going up, up, and up. And by the way, we're over 1.6 million doses now in the state of Kansas, which I think is pretty good. 18 plus, over half have received their first shot. And Dr. Hawkinson may want to comment about I breathe easier knowing when people get at least their first shot, and yet those variants are looming over us, and we're following it very closely and can respond very quickly with mobile units and a strike team should there be an outbreak as a result of that.
Yeah.
So you've mentioned there that the wastewater testing picture shows that some communities are seeing a decrease in disease, and others may have a bit of a different disease burden than we see in symptomatic testing, PCR testing, for those who are seeking out tests because they're ill. What would you say to those who feel like they don't need to get tested because people around them are vaccinated now?
I think that's a bit early and too preliminary to really make that. There's still a lot of asymptomatic infections going on there. We know that it's also in younger people. And it's interesting because the younger people are also the more vaccine hesitant. There's this what we call the movable middle. There's a middle percentage, I don't know, 25% maybe of Kansans who are saying, well, I want to wait a little bit longer before I get it, but I probably will get the vaccine. That's different than the vaccine hesitant person who says, I will never receive this. And that group is the predominant age group is 18 to 35. And yet they're the ones that are quite likely, because of gatherings and the like, to become infected and even asymptomatic spread. We've got a campaign going on have for a while called, quote, "Know before you go," unquote. In other words, before you go home after this college school year, get tested so that you don't carry the organism back home. Before you go visit grandma over the weekend, who might still be vulnerable, to get tested. We think that there is still the need for widespread testing. Testing in all the states is going down, despite our efforts to promote it, and still free. I think we just need to keep at it and accelerate, because now, at least in the state of Kansas, the widespread wildfires are essentially put out. But there's still hot spots that flare up. And the testing will tell us where those flare-ups are occurring so we can go in and put them out.
You mentioned a strong vaccination picture as well. 50% of those over 18 having a first dose, 1.6 million doses. How does that sort of play into the picture of herd immunity or population immunity, and what do we need to do to get to that point in Kansas where we feel comfortable that other mitigation strategies might be able to be backed off of a touch?
I think it's just a matter of keep on doing what we're doing, but get vaccine off of shelves and into arms. And we're at kind of an important inflection point right now, I think, in that even a few weeks ago, the demand was markedly outstripping the supply. And as you pointed out, David, you've got vaccine available and you want to put it into people's arms. That is occurring statewide. We've had a number, 50 vaccinating sites that say they have open vaccine appointments, and have not requested allocation of vaccine for a week or 2 weeks. In other words, taking a pause in the vaccine allocation, which is okay, because we want to not have it sit on shelves so we can reallocate to those counties, for example, that have continued strong demand. But the demand isn't universally strong throughout the state. I think that's a problem, because I know those areas where demand is not strong still has a lot of people who should be vaccinated. So if I had one message, it's do whatever we can do as a medical and public health community to drive demand by making it easy for people to get vaccinated, and emphasizing safety. And remember, they really believe they're medical providers more than anybody. The public does. So don't be shy about getting the word out. This J&J thing may be a speed bump that is going to cause us problems in terms of supply chain ultimately, but it shouldn't cause any hesitation in terms of the existing other two products that are out there. We have not seen these complications or any dominant complication in the Pfizer and Moderna. So go get vaccinated.
I think another point about that is, if we're on the topic of herd immunity or population immunity, there was a very insightful question yesterday about, well, what if the children can't get vaccinated yet? So they are working on studies to look at safety and efficacy in children. But I think that was a very insightful question, because population immunity is based on what? The amount of people that are susceptible and can spread the disease. And we certainly know children can spread the disease and are susceptible to the disease as well. So you are keeping a whole segment of the population out. That's why it's even more incumbent upon the adults, upon those 16 and above, to get vaccinated now while they can.
On the topic of vaccines and what you can and can't do, or how you act after them, one of the questions that we're getting frequently is not about what is safe to do or what not, but instead, do I need to prove that I'm vaccinated? Do I need to take my vaccine card with me if I'm going to a restaurant or traveling? Dr. Norman, does the state have thoughts around COVID passports or vaccine passports or any other sort of documentation requirements about how people need to think about proving they're vaccinated?
We're watching this discussion unfold, and there can be arguments for both sides, obviously. We think it's a mistake to necessarily throw the doors open and say, well, if you tell me you've been vaccinated, then then there's no chance of disease transmission. We know that that's not the case. None of the vaccines are 100% effective in preventing infection for the great period of time. We do know that cohorts and families that are entirely vaccinated are less likely to catch the illness. But we have not taken any steps to making a vaccine passport. Now, there might well be businesses, such as cruise lines, for example, that require that of their own staff and people who are vacationers on those ships. But we have not taken those steps in the state of Kansas yet.
All right. Jill, let's get a couple of questions from the community this morning.
Yeah, I'm going to start with Kim. She says, can you clear up for people when they get together after the first vaccine, Moderna or Pfizer? She said, I was told the first vaccination is for preventing and the second is to prolong the effectiveness. So if you get the first vaccine, can you meet up with people?
No, I think that that information is a little bit misguided. All of the guidance that has been re-released or updated is based on really 2 weeks after that second dose of vaccine for Moderna and Pfizer, or if you've got Johnson & Johnson, 2 weeks after that dose of Johnson & Johnson. That is when you have optimal immunity, and so far from what we know from the studies, the optimal durability as well. We know that during that first dose, you start to prime your immune system to identify the virus if you encounter it. That second is really to boost that specific immune response as well. So I think that's kind of cleared up.
No doubt there is benefit from the first vaccine, right? You should get it as soon as you can. You get some immunity developing over the 2 weeks between your first and your second, if it's the Moderna or the Pfizer. But the sort of peak of the immunity and the point at which the CDC guidance says you're able to go out and interact with others who might not be vaccinated if they're from one household is 2 weeks after the second dose for a reason. The combination of all those things that Dana just mentioned is what gets you to that point. So clearly benefit from one dose, but it's not the point to go out and say, let's have a party.
And that's not to say that guidance may change in the future. Those questions are being asked and studied, but those were not the questions in the trials to approve or emergency use authorize the Moderna and Pfizer vaccines. So.
John asks, is the AstraZeneca vaccine in Europe being investigated for blood clots?
I think it has been. I think the European Union or the European Medical Agency, I believe, is still recommending the use of that AstraZeneca, from what I remember.
Right. It was paused for questions, maybe very similar to the J&J question, based on recognition that there may be a correlation or a higher incidence of some sort of blood clotting in those who had the vaccine. And after the review, the answer was it's safe to use. There's no increase in the risk over baseline. The reporting systems did a great job of reporting blood clots in those who had their vaccines. And when we got to the bottom line, looking at the rate of those blood clots in the community in Europe versus those who've had the vaccine, there was no difference. And the vaccine was recommended to be continued as part of their rollout plan. So maybe similar to what we'll see here. Time will tell. But there were for sure questions, and the proof at the end of the day was that this was just what was going to happen anyway. Yeah,
and I don't remember if some of the countries have only advocated for use in certain populations or restricting it to others, about based on age or gender or anything like that. But overall, it's still in use and still recommended by the World Health Organization.
And for the panel, Matt wants to know, he says he has a variant question. And his question is, you know how this is, sometimes this gets, all right. All the variants are B lineage except for the P lineage coming out of Brazil. How can a variant come from a different lineage? Science class.
I'll take a shot, but does Dr. Norman want to take a shot at this first, or we'll give?
No, break a leg, Dana.
Okay. So, I think what we have to remember is a lot of these lineages are based on very specific genome sequencing. So they are getting down to the base pairs of the genome, of the RNA of this virus. And there's 30,000 base pairs in the genome of this virus. So they have the original strain from Wuhan. We call it the Wuhan strain, even though they're not different strains. Let's be clear about that. But the Wuhan isolate or the Wuhan strain. And from there, they can do whole genome sequencing on every other isolate that they've ever obtained, if they have that, if they still have them, and look at the changes in those base pairs. And so based on the amount of changes or specific changes within that genome, they put them then into different lineages, and that's why you have lineage. You have an A lineage, a B lineage, the P, and then it's B1, B2, or P1, P2. Basically, it is just based on really those specific changes within the genome down to the level of the base pairs in the RNA genome. And that's how they do that, basically.
I think the last question, especially since Dr. Norman has like 2 minutes, a lot of people, they just really are concerned about the Johnson & Johnson news today. They're asking questions like, why women? Is it because maybe they're on birth control and taking other medication? Isaac's wanting to know, do you think that this is going to make it difficult to get vaccine hesitant people to go ahead and get the vaccine? So maybe just some kind of discussion around why, and why are the blood clots happening in the head? They want you to tell them that too.
All right, Dr. Norman, you want to tackle all those in a minute?
I'll tackle all those but one. Yes, it does make it more difficult, and I can fully understand why people who are somewhat riding the fence anyway would take a pause to reconsider whether they should get it. I mean, that's a normal, informed human response. It does make it a problem for our vaccine rollout because, for example, when the Johnson & Johnson product first came out, you'll recall it was ostensibly a little bit less effective. And then later on, because it was one dose, it became everybody's darling. So it means that we have to do more and more fine tuning and customization. You know, the big mass vaccine clinics, at least in Kansas, are mostly behind us now. I know that there could be still some, multi-thousand dose clinics that are offered, and we'll do that. But we have populations, for example, that don't want a vaccine that was grown in fetal stem cells, for example. Okay, so then we have to adjust to use one of the other vaccines. There are people that now that I suspect that we'll probably ride through this with J&J, but time will tell. It means that people are starting to have more and more opinion. It used to be, I'll take whatever vaccine you can give me and I'll take it as soon as I can. And now people are starting to have more opinions, and I think that's fine. It brings up questions that must be answered. The question about the central venous thrombosis and that venous complex of veins deep in the brain that Dr. Hawkinson mentioned, I don't know why it would have a particular propensity for that venous system as opposed to the Dr. Weil talked about in the legs and the other extremities and whatnot. I don't have a good explanation for that. Maybe the examination team, maybe that at the FDA and CDC, maybe and the scientists that go along with that, maybe they'll come out with something.
Yeah. Thanks for those answers, Dr. Norman. I know we need to give you the opportunity to make an exit here very shortly. Anything else you'd like to share before you leave us?
And you guys might want to comment. I know Dana knows more about it than I do. And that is that these monoclonal antibodies that we've been using with a great deal of success, I think, now there's some new information coming out about the monoclonal antibody cocktail, quote unquote, the Regeneron, and probably soon to follow other products that have been shown to be effective in preventing infection in people that are living with somebody with an active infection. So the way I think about it in context is, and where will this fit in? I'm not sure yet, but people can get a subcutaneous, so it's just an under the skin type antibody administration, not IV, to prevent them. It prevented 81% of the people from getting infected, which would normally expect higher transmission. So these monoclonal antibodies may indeed have a place for the prevention of COVID-19 in people that, because of exposures, are very high risk. We'll have to get back to you later on the details of that, but Dana may have a comment on that, I'm not sure.
Yeah, I think it's good news. We are giving the monoclonal antibodies now across the nation. There's just a problem with access and the ability to get to that infusion center. Also, again, these are for active disease. So with the monoclonal antibodies, you really want to get within that first week of symptoms. This, as Dr. Norman mentioned, was for prevention if you are living with someone. They showed that the IV formulation was pretty good at preventing nursing home infection. This is for other home household contacts, but just as he stated, it's not an IV. It is just a needle, and you get it under the skin. I think the important thing to remember here is, number one, are we going to be able to get the doses, and will there be good, ready access? But with that, I also think we really need tight control and regulation over those, as well as good surveillance about what variants are going on in your community. We saw that one of the monoclonal antibodies really doesn't have any effect now, and that was the initial Eli Lilly monoclonal antibody with just one. They have since added another antibody to that to create a double antibody cocktail, which looks to be effective. The Regeneron products still look to be effective against the variants, but as other variants come out, and I think we need continued surveillance to really understand what variants are circulating in the community, so you know that if you have activity against that particular variant that is causing the disease. But I hope this is one more step to, number one, preventing disease, to prevent hospitalization and death, but also preventing spread if you can get those household contacts to get this antibody, this subcutaneous or subdermal antibody treatment, again, to keep people well. And one more thing to help prevent the spread of disease. So,
yeah, very important in the process. And I think good news, to be sure.
Yeah.
All right. Well, tomorrow we have Dr. Catherine Satterwhite, Regional Health Administrator for the U.S. Department of Health and Human Services. She'll give us a regional overview of infection and vaccination rates, plus offer her thoughts on vaccine passports and how to carry or care for your vaccination cards. As we wrap up, Dr. Norman, final thoughts?
No, I think let's keep an eye on this J&J issue. It's going to unfold, I think, relatively quickly. The one thing that I want to be able to answer people, and I just don't have it right now yet, is if they were scheduled, because we have so many different kinds of vaccination sites, pharmacies and health departments and hospitals. I think the thing that'll be tough to manage is if those people out there have J&J appointments and they are put on pause, can we be nimble and respond with a Pfizer or Moderna vaccine for those who want it? So just keep an eye out, call the vaccinating site or the sponsoring entity and see. I would like to be able to pivot and vaccinate those people with either the Pfizer or the Moderna if they're willing to accept it. So we'll give it that shot. No pun intended.
Thank you, sir.
We have a lot of questions still, and so I want to make a promise that we'll get to these tomorrow since we're wrapping up. But I do know one thing that maybe you could talk about in your closing remarks. A lot of people asking about masking after they've had the vaccine. Yeah. Some people have had transplant. They want to know, we're both vaccinated. Does my husband still need to wear a mask? If you could just talk about masking and vaccine, I think that would address a lot of the questions.
Yeah, I mean, I think to start with those specific questions about transplant or medical conditions, please talk with your medical team. As an overall guidance about those that are vaccinated, we still recommend masking and doing those things. We know that there has been updated guidance based on people who are fully vaccinated, again, which is 2 weeks after the second dose of Moderna and Pfizer, or 2 weeks after the dose of Johnson & Johnson. We're people that are fully vaccinated, and for the most part, this means households. Correct. So it's not just the two people, but if there are kids in there, then you would consider really that household not to be fully vaccinated. But people are still going out and doing those things, even if the rest of the household is not vaccinated, if that individual is vaccinated. But the guidance is that you are able to, if both people or both parties are fully vaccinated, you can meet without masks. If you go to someone who's not fully vaccinated to their house, you are able to meet with one household that is not fully vaccinated, provided that there is not somebody at high risk of disease there. So we still have to do the masking. Is there a question of can you transmit it less? We certainly have seen those signals. Right now, there is a study underway of, I believe, 12,000 college students across 20 universities or more looking to answer that specific question. So the study design is specifically looking to answer, if you have been vaccinated, can you still transmit the virus? Again, they're enrolling it now. I don't know when the full data will be out, but they are looking at answering that question. We certainly have the signal that you probably are less able to transmit the disease. And we know your overall spectrum of disease is going to be much less if you are vaccinated. You probably won't get as many symptoms or as bad, and we know you will be protected from hospitalization, severe illness, and death compared to if you weren't vaccinated. So again, that is why we still need to do the masking. We suspect you can probably transmit it less, but we don't know the full answer to that question. That question will be answered in the near future.
Yeah. I think to further reinforce this, even if you individually are vaccinated, because only half of the adult population in Kansas has received a single vaccine yet, what we are seeing today is that every one person who's infected in Kansas is infecting just over one other. It's why disease continues at about the same rate, with a few, maybe more each day than we had seen before. Just a way of saying disease is not contracting in our community. And until we really start to see that, that's the marker, or that sort of herd immunity or population-based vaccine immunity is at the point where we can start to remove things like masking. We're going to keep needing those other interventions, especially in public. Now, the guidance of course, a group that is completely vaccinated, gathering without a mask is very fair. But in the big picture, we're still seeing each infected person infect at least one, and actually slightly more than one other. And so disease continues to be transmitted at exactly the same rates, not falling in our community. And so that really, at the end of the day, is the big picture. Yes, right, individually in your own controlled environment, right, small groups where you know everyone has been vaccinated, gathering without a mask is safe. But in the big picture, we don't know that when we go into a restaurant, or we don't know that when we go to a soccer game, or you name it, right, interacting with lots of different households. So that's, I think, the best guidance we have to offer at this point. We'll get there. There is absolutely an impact individually and collectively to our community from vaccination. We're just not quite at the let's remove the other intervention threshold yet, based on the number of people in our state. So, all right, well, as we close today, we have 6,500 opportunities to get a vaccine here in our system, and another 6,000 doses coming this week. There are 3 ways for you to book an appointment if you're interested in receiving vaccine here this week. If you're a patient, you can always book through your MyChart account. If you've not been a patient here before, or if you don't have MyChart set up, you can always go to our website, kansashealthsystem.com/vaccine. Or if you prefer to call us, our team would be happy to help. The number to our call center is 913-588-1227. And with that, have a great week, safe day today, and we'll see you here tomorrow.